Hey, there he is. Hey, Robert, thanks for joining. Video's looking good. Can we just test out your audio real quick, Robert? Okay.
Thanks for joining us, everyone. Looks like we're throwing a number. We're going to get started in just a few minutes.
All right, yeah. Okay. Apologies. Got a dog who thinks he's tough. The perils of Zoom calls at home. Welcome, everybody. Thank you so much for joining us today. I want to get just a few logistical things out of the way because we do have a tight agenda, and I want to leave as much time for discussion and questions as possible, as well as respecting everyone's time. So my name is Chris Jones. I'm a project coordinator with the Rocky Mountain Public Health Training Center at the School of Public Health, and I'm also the communications director for CPHA. And I am happy to be here today to talk about some important issues with our current events in health equity. We have some wonderful speakers, but just up front, so we do have some session support. Mia Crandall is our instructional design lead. If you have any issues, do feel free to privately message her, and she'll walk you through any audio troubles or things like that. Please save your questions for now until the end, because we're going to try and fly through straight through the presentations and then get into some breakout discussion groups where we'll actually separate out the whole group today into separate rooms, and then reconvene for some sharing back and some final thoughts. So without further ado, I will turn it over to my colleague Sarah Boland for just a brief review on the agenda.
Yeah. So thank you, everyone, for joining us today. My name is Sarah, and I'm co-organizer with CPHA's Health Equity webinars, along with Marissa Westbrook, and then Chris Jones helps support us as well. Just wanted to first begin by acknowledging that a lot has changed since our last webinar. We're living in a strange and admittedly devastating time. And so that's just to say that business is not as usual. Your dogs are here, it's okay too. Your kids, we're in a new norm. And so just want to create a kind and open space for everyone in this discussion. So we'll start by hearing from our 4 speakers today, who bring their own perspectives on how COVID-19 has impacted our communities, often in inequitable ways. And then we'll just take some time for breakouts and return as a group to debrief for about 15 minutes, if that sounds good to everyone else. So our first speaker today is Nami Thompson. Nami consults in multi-stakeholder, multi-sectoral dialogue around health equity, public policy, civic engagement, and land management. She is currently with Colorado Public Health Association as the Health Equity Coalition's Community Engagement Work Group. Her areas of expertise are subaltern studies, urban policy analysis, gender parity, race consciousness, and community organizing. So I'll just hand it over to Nami. She's going to speak for a few minutes.
Hi, everyone. Thank you so much for that introduction, and thank you for having me here. It's always an honor to speak with everyone here. I'm going to stop my video and just chat with you all. You can see my my other bio photo there, my headshot. Today I'm here to chat about the impact of COVID-19 on Asian Americans in particular. We've seen as of late in the US an increase in the number of incidents of xenophobic assaults and incidents of harassment against Asian Americans, especially women and elders. Some of the more widely circulated stories that you may have seen are the stabbing of a family of 3, including their 2-year-old child by a white man who said, quote, "I want to kill Chinese people." And another incident in which an East Asian woman was attacked with acid poured down her face while she was taking out trash. Anti-Asian rhetoric and sentiment in the US isn't exactly new. At the turn of the century, a West Coast-based hate group called the Anti-Asiatic League, comprised of white politicians, business people, and working class, displayed open hatred for Asian immigrant workers and advocated for the closing of borders, which sounds super familiar. And especially in places like Bellingham, Washington, they created movements to stop Asian workers from, quote, taking their jobs. They engaged in things like violent beatings, lynchings, and other tactics to, such as the racialization of disease, food, language, and religion to create contempt and disgust in the American psyche for Asians, even in the minds of Asian Americans themselves. So that's really, you know, how we became the perpetual foreigner. And it comes as no surprise, of course, now that the Asian diaspora, whether we're talking about East Asians, South Asians, Southeast Asians, when something politically controversial hits or a public policy goes, you know, awry, we're the foil for a lot of poor disaster preparation and management. And this is something that became abundantly clear to our communities after 9/11. And it is something that we're seeing again from our political leaders, particularly when we see the use of phrases like China virus, Wuhan virus, Kung flu. So, you know, having worked with groups after 9/11, it took 15 years of work from all Asian American communities, as well as Muslims and Sikhs of all races, to see a decline, a meaningful decline in hate crimes since 9/11, and now we're quickly seeing that undone with just a few signal words. So that's where that's at. To get into some of the details of what we're seeing, Representative Lee recently reported last week that at least 1,600 hate crimes have been reported throughout the community-based systems, not to the police, since late January. And 1,100 of those were reported within just that first 2-week period. That's pretty massive as far as numbers go. We're finding that Asian Americans are also, they're at risk at multiple levels. So, for example, the US healthcare infrastructure is heavily propped up by nurses, many of whom come from the Philippines and other Southeast Asian countries. Filipinx people make up 1% of the US population, but 4% of the population of US nurses. And 30% of New York State's Filipino population are healthcare workers. So that's 150,000 Filipino people, Filipino nurses nationwide. And they're the ones who are coping with no protective equipment, low pay, poor working condition, and acts of racism from patients and intimidation from employers for speaking out about it. One Filipino nurse in New York reported being spat on in the face by a white man who was a COVID-19 patient while she was administering his medication. Malaysian and Bangladeshi immigrants are also represented in super high numbers, not quite as high as Filipino people, and they've reported similar experiences. The same individuals are subject to racial slurs and harassment while they're out doing things like shopping for, you know, stuff for their home, trying to get toilet paper, right? They don't get hazard pay. They risk exposing their families to the virus. And in an ironic full circle, they go to seek treatment, and especially South Asians, Southeast Asians are reporting discrimination from white clinicians when they go to seek treatment. We're also looking at higher numbers of self-reported suicidality and depression among Asian Americans across the diaspora. We already know that this is a crisis in this population. It's been an area of concern for at least 2 decades, and now we have compounding factors that there's twofold. One is, of course, the anxiety and fear of hate crimes. 2 is the prevalence of guns in homes. So gun stores, of course, are now an essential business for some reason. And gun ownership rates have increased since this virus, because I don't know who's going to shoot at a virus, but Asian American households have been, lower on the end of gun ownership, but those numbers have spiked, especially on the West Coast and specifically after the acid attack, which occurred on the East Coast. So there's clear reason to be worried about increased gun-related death, particularly by suicide amongst Asian Americans. And, I also just personally want to address that there's a very small but very vocal group of Asians who believe that if they, assimilate, if they make a show of hyperpatriotism, if they adopt individualist beliefs, to the extent that they're advocating for public policy that can harm other identity groups, that that they'll be safe, and in fact they'll be enforcing white supremacist models of racial hierarchy. And many of us who belong to civil rights, many of us Asians who belong to civil rights coalitions, are not believers in any of those things. And we recognize that there are ways in which we can reinforce anti-Blackness if we do this. If we do this in a way that does not involve conversation with people who are affected by the criminal justice system disproportionately. So really, that's something that's very critical to our community when it comes to how we address reporting these crimes. And I'm going to wrap up. And while it's true that public health does need to focus on equity as we move forward, it is also public health that historically once decided that Asians are inherently carriers of disease because, quote, they eat weird food and lack good hygiene. As I watch a kid eat a Hot Pocket. It was once public health that quarantined San Francisco's Chinatown during a breakout of the bubonic plague. Public health historically has supported race science in the past and anti-miscegenation laws. And when I learned about the unjustifiable internment of Japanese Americans, there was one narrative of hope in there that I found, and that was of the Japanese health workers who, at great sacrifice to themselves, vaccinated their neighbors just prior to being interned. Some of them gathered as many sanitation supplies and as much insulin as they could carry. They helped other interned people give birth. While detained, they prevented people from eating spoiled food. They protested for better care and actually successfully got a little bit of it. And it was the most that any individual could do, every individual could do for the well-being for those around them. And I think and I believe that public health has an obligation to repair past harm and to bring wholeness and justice as a necessary step towards equity. And so that's really where I believe we can learn from this experience right now. Thank you.
Thank you for sharing, Nami, and for your insightful words. Next, we'll have Robert Franklin share. I think Chris is going to pull up his bio real quick. I'll start reading it while he brings it up. So Robert is joining us. He is the lead for Diversity, Equity, Inclusion Programs and Initiative for Children's Hospital, Colorado. And so he works with community-facing work with his passions, and his position has led him to volunteer as the Senior Director of CPHA's Health Equity Coalition, working to bring both hospital resources and openness to accountability for forwarding the work towards health equity. So pleased to have Robert with us. Here's a quick snapshot, great headshot of him and his bio. And Robert's going to take it away.
Oh, I wish my hair still looked like that right now.
Good luck.
I did hear from the barber that we will be able to get back in May. So there is hope on the horizon for this look that I've got going on right now. Greetings, everybody. Good afternoon. I want to start by just thanking you for being here, and certainly thanking Nami for that perspective, for that honesty, that accountability in this time. I think it's awesome and humbling to follow you in this situation, in this conversation, representing a health system, because certainly much of what you're talking about is connected to the failure of the health systems in our country and really internationally, to understand that this is all really preventable. The human harm that we are seeing, that you described, Nami, and that we are seeing in other places is really preventable. Not that we have to talk about where did the virus come from and whose fault it is that it is a danger to us all, but really the fact that our health systems are not paying attention to and have not been paying attention to health disparity from the jump, and have been actually implicit in continuing them, is the reason we are in the situation we are. As a health system, and I'm going to follow Nami's honesty and accountability. As a health system, Children's is no stranger to being really propped up by what we would call elective procedures, things that we would charge a lot of money for and get a big reimbursement for, have stopped. All that stuff has stopped in an effort to keep folks safe. And at the same time, that's hurting the coffers and impacts what we would do in community health or in public health. So because we have been backwards in just treating the sick, right? Only taking care of the pieces that are broken, as opposed to being preventative and being out in the community to build healthy communities. We're in the situation where now when we don't do elective procedure, and by elective, I mean those that are just scheduled. So that doesn't mean it's non-emergent stuff, that is not necessary. Then we have this conversation that's going on right now, and not just at Children's Hospital, but in all hospitals, about how do we go back to normal with a slimmed down employee base, with a slimmed down programmatic base, and that we don't have the same outreach that we used to have. Never mind the changes that, because of our COVID-19 response, we have so many more people who are out of touch with their care providers, who feel a deepened fear with getting access to hospitals and care providers, because telehealth actually is not the most safe way to get the care that they need. And so it's backwards, and we are seeing that now. And not every organization is responding the way that we would expect them to, and so we have to hold them accountable. Here at Children's Hospital, I lead the diversity, equity, and inclusion programs, and it may or may not come as a surprise to you that before the national conversation on race and ethnic impacts by COVID-19 diagnoses and deaths, we weren't talking about it. We weren't thinking about it. And I'd even back up further and say that because we're a children's hospital, we're a pediatric health system, we were holding on to this narrative that because it is affecting older people, adults, seniors, and the immunocompromised, that it wasn't going to be as big of an issue for us to be impacted by. But that conversation was short-sighted in that we were just talking about the numbers coming into the hospital, not the fact that out of the 7,500 staff members that we have who work for Children's, that we might all be connected to someone or have to care for someone who might be vulnerable or contract COVID-19 or show symptoms, and have to care for them, and that change our livelihood, and that would impact certain people differently than it does those who sit in leadership roles, management roles, or in the highest of roles, right? So because we weren't even looking at that, and that's a work in progress anyway, out of the office that I sit in, many of these things are exacerbated, and it is my role, but is the role of others to actually bring this up. So when we're talking about some hospitals, not at Children's, but some hospitals are looking at reducing their staff size by about 30%. Well, who's that 30%? Who are we looking at to say that, well, you can't have a job, or you won't have a job here anymore, or we need you to go to 70% FTE as opposed to 100% FTE? How do you choose that? And if you're not paying attention to those who are already at risk for lower levels of access to not only healthcare, but the other benefits that come with having full-time employment, having having a kid at home, or having a dependent at home who needs to be taken care of. If you're not already focused on those things, then those impacts are going to be even graver. Right now, we at Children's are talking a lot about unemployment roles, rather. Who is asking for unemployment? Who's able to stay at home and who's not? Who has access to the internet at home, and why aren't they checking their emails? This conversation is about health equity, but it stems from the fact that we didn't start this from the beginning with the right focus. And so we're not prepared to deal with the consequences that are impacting certain groups differently. And so when we get into our breakout groups, we can talk even more about what does that mean for pay insecurity and food insecurity, and what that means for people who are out of work or people who don't have access to their clinicians the way that they need to. So I'm looking forward to more of the conversation, and just thanks for everybody being here.
Thank you for sharing, Robert, and for being so frank and honest about there are real impacts of this epidemic on on our coworkers, our neighbors, our families, ourselves. Next, we're going to have Marissa Silverberg speak. She's currently serving as the COVID-19 Lead Community Resource Coordinator at Jefferson County Public Health. We used to work together. In this role, Marissa coordinates a variety of information sharing and gap analysis with a primary focus on the needs across the food system. At the moment, she's working on some significant improvements to distribute food for the county, from emergency food provider coordination to economic stability for Jeffco farmers. So we're excited to have her, and Marissa, feel free to unmute and begin when you're ready.
Awesome. Thanks, Sarah. And I just have to shout out to Robert, because I, as a former New Yorker, when people said 5 points for the first few months I lived here, I didn't understand that it was a neighborhood. I was like, why are you talking about New York? So I appreciated seeing your background today. Hi, everyone. My name is Marissa Silverberg. I work at Jefferson County Public Health, like Sarah said, primarily work on food support during the COVID-19 crisis, and outside of that crisis, work on food systems at Jeffco, and have connected in with some of the other resource needs throughout this crisis. And so a few of the things that we've really started to see, a lot of really significant issues, honestly, before COVID-19 in relation to federal policy around public charge. I think we're starting to see an increased fear leading to greater food insecurity in our community that I think, not to speak for other counties outside of Jefferson County, but I think from hearing from colleagues in other counties, there are similar fears within the Latinx community to access food resources and look for food, going to food pantries. We've worked with a lot of pantries on Know Your Rights trainings, and if ICE is to approach, I know we got 1 or 2 calls about that from folks. And another piece of that, not just for folks living in a climate of fear, but as well for folks with varying levels of limited access to travel, whether for quarantine or for various physical or emotional reasons. A huge part of this has really been lifting up distribution. And so I think there are definitely folks who are still not able to hit, but there's been clear gaps that I think a fair amount of us have recognized prior to COVID that have really just escalated in this crisis around distribution of food and distribution of resources for folks who are unable to leave their homes. Jefferson County, for those who are maybe not as familiar, is to the west of Denver, and it has a fair amount of urban and suburban space, as well as a fair amount of mountain and rural population and space. And so just balancing kind of those two different geographies has been interesting in terms of having effective distribution in place. Another piece that we have really tried to push on, and I'll say this just in case I speak out of line, that I'm speaking on behalf of myself and not Jefferson County Public Health, in terms of looking at structural inequities around the economy. And so I think it's been really encouraging to see how much funding throughout Colorado has come out into this crisis to support food and PPEs and other needs. And I think there's been a lot of conversations with farmers in Jefferson County around how to best support them as essential workers and support their small businesses in Jefferson County without all of those funds for food going to kind of these big ag and big food providers. So we've really tried to work with farmers to start to look at that. And I know I've heard from other counties in the state who have more of a kind of larger farm operations than we do in Jeffco, about just the pressures on farm workers. And I think as well, just looking at need for policy support for essential food workers. I think we're seeing a tremendous amount of need from workers who are working 70, 80 hours a week that may have gotten a bit of a boost, but still don't have certain protections around paid leave and things like that. And I think the other question is, acknowledging that COVID is going to be a long-term response and that these are a lot of policies that have come up throughout conversations over the years. What will it look like to adopt things like paid sick leave, increased minimum wage, things like that in the long term versus just being a Band-Aid during this time. So I really look forward to having more conversations to also see at not just a federal, state level, but on a local level, are there policies that folks are looking at or that we should be looking at to really better sustain some of those supports for our workers at this time, and also ensure that food insecurity, housing insecurity aren't as prominent as they are. I think it really hit me this week in particular to really face even the fears of our healthcare workers who oftentimes are food insecure themselves, and now have this fear of being that much more connected to potentially having COVID and not wanting to go into the grocery store. And I think that was even something I haven't thought about, is how are we supporting our healthcare workers in getting this access to basic need as well. So thank you. I look forward to chatting more.
Thank you, Marissa. We just have one more speaker. Brian wasn't able to join us here today because he's working hard connecting folks with the service they need at Denver Health. But we were able to record ahead of time because he was really excited about what we were doing and wanted to share. So I'm just going to read a little bit about him, and then Chris is going to share his video, after which we'll do our breakout sessions. So Brian Polivoy is working in the mental health field. He's been doing so for 17 years now, working with varied populations. Brian spent many years specializing in the areas of trauma, grief and loss, men's issues, veterans, disabilities, intimacy, and sexuality, working with both able-bodied and disabled populations in order to aid them in achieving their goals and improving their quality of life. Brian has had the opportunity to affect change on much larger scales to enable true transformation change and an increase in the health equity of Denver metro community, the state, and Colorado and beyond. He's also worked as a professional public speaker and educator, and I'm sure they'll come through in his sharing his story and his perspective. So Chris is going to share that real quick.
Hello, and thanks for giving me the time to come and speak with you. My name is Brian Polivoy, and I'm a licensed clinical social worker, and I'm actually a member of the Health Equity Coalition, and I'm doing this on behalf of Colorado Public Health Association. And I'm really glad to be here and talk to you about the psychological impact of COVID-19. As we move through these challenging and ever-changing times, I'd like to take a moment to look beyond just mere survival or just thinking about getting back to the status quo, and what the lasting effects of COVID-19 could be on those who stand to lose the most as a result of this pandemic. Those folks about whom I'm speaking are those who fall into a category of medical fragility. These people who, for whatever reason, are more susceptible to COVID-19. That includes people with pre-existing conditions, such as physical disability, developmental disability, debilitating illnesses, both physical and psychological, or people of lower socioeconomic status who don't have access to the basic safety measures that we all have come to rely on over the last several weeks. As a member of this population and a mental health and medical professional, I thought it would be my duty to speak about the potential psychological effects this pandemic is having on this population, and what simple steps professionals and ordinary people can take to recognize those in emotional distress so that we can help ease the burden through this trying time and beyond. Let me take a moment to talk to you a little bit about myself so that you understand why I felt it's so important for me as an individual to speak on this particular topic. I've been in the mental health field for 17 years, and I've worked with folks ranging from 0 to 99 and in between with disabilities and different types of things, and I've worked with all different populations. So I understand when you talk about medically fragile individuals, just who we're speaking of with regard to COVID-19. I also happen to be a person who has a disability. I have cerebral palsy, and I use a wheelchair to ambulate, and I have other outstanding medical conditions. This makes me part of the very population of which I'm speaking, and actually brings home the importance of making sure that folks understand how deadly this can be to so much of our population that normally doesn't even have a voice. So let me talk a little bit about the psychological implications of something like COVID-19. So when you think about what we're going through, when you think about the idea of having to isolate, of having to wear masks, of having to do all of those things, what many people who don't have understanding of what psychological effects don't realize is things like that can be triggering to folks who have been through trauma, particularly those who have been through sexual trauma or physical abuse or any kind of thing where they were taken away from the normal world, where they were forced to do things they didn't want to do, where they were put into a place where they had to abide by strict things that were not normal. And so when those things get put into place, it can also cause a problem for individuals who have experienced this in a bad way and then re-trigger them into those responses and have those things happen again, which causes a whole host of issues for those just trying to get through the day like the rest of us. One of the other things that we're dealing with also is something known as white coat syndrome. Now, white coat syndrome, for those of you who are not aware of it, is an unconscious response for those of us who have been involved with the medical professions for most of our lives and have been almost guinea pigs and have had a lot of surgical procedures or had a lot of time in the hospital or anything like that. When folks have to go into that kind of environment, there is an unconscious, almost traumatic PTSD-like response, which causes folks to have uncontrollable emotions, maybe have higher blood pressure, maybe cry, maybe shake uncontrollably, all those different kinds of things. And there are specific triggers like masks, like isolation, PPE, and all those types of things that do actually trigger those responses. And although folks need that for what's going on right now, the unintended consequences of that, and the unintended consequences of the isolation can actually bring up issues of polytrauma and issues of white coat syndrome that make things way more difficult for people just to survive. And so active mental health symptoms are on the rise. So suicidal ideation and homicidal ideation become a problem because folks can't escape anything. Before, you could compartmentalize and say, oh, this is something that I have to deal with in the doctor's office. So although it is difficult for me, this is something I can do. Now you go out for a walk in the park, you go to the grocery store, and you're constantly confronted with those very things that are triggers for you. So that's something that is a real large problem for many of us in this society and for many folks that are dealing with things. Therefore, it's actually triggering increased feelings of anxiety, depression, and hopelessness. Now, the other side of this is actually folks who use a lot of the equipment that people with COVID-19 have come to rely on. So when I think of that, I think of the idea of folks that use ventilators on a regular basis, and folks that would be considered by the society at large to be more of a burden than a benefit on society, which isn't true, but that is the perception. So the idea of folks having to be triaged, although that is not something we're doing here in Colorado, and nobody really is doing that, is something that folks have a great fear around, because if you come into a room and there are 3 people and 2 ventilators, who are going to be used as the criteria to choose who is worth living and who is worth dying. And that's something within disability circles and within medically fragile circles is something that's going on and something that people are truly, truly afraid of and discussing both as advocates and just as people in their normal day. So when I think about all of these things that are going on, which I know can be seriously overwhelming, I want to give you guys what I call the picture of what emotional flooding looks like. So emotional flooding is when your mind and your emotions start to race so bad that everything just kind of muddles together. And so what the worst case scenario you could imagine becomes reality, and you really can't slow yourself down, and you really can't think of anything at all. So when I look at that, I think to myself, how's the best way I can explain it? And the way I can explain it is the idea of a jigsaw puzzle. Now, many of us out here have done jigsaw puzzles before. And so when you look at a jigsaw puzzle and it's got a picture of a puppy, and the puppy's really, really cute, and it's holding a beach ball and it's really, really happy, you're like, wow, I can't wait to get this to get together and look like the puppy. Then you dump all the pieces on the table. It's a big mound of pieces, and you're looking at the picture of the box. You're saying, oh my gosh, I have no idea how the heck I'm going to get this mound of pieces to look like this beautiful little puppy on the box. And you'd almost be overwhelmed. And then what do? We decide to, break apart the pieces into usable sections, and we start maybe on the top corner. And then we do the borders, and we go around the borders, and the borders come together. And then we start going inside and into the middle, and we start putting one section of the puzzle together, and then another section of the puzzle together, and another section, and another section. And then what happens after that is we start to see, holy cow, that pile of pieces that made no sense is now starting to look like that puppy. Why? Because we took everything step by step and piece by piece. That is how one deals with emotional flooding. So what you need to do is you need to stop. And you need to say, okay, I can't deal with all of this COVID-19 things. I can't deal with all of my medical things. But if I take things step by step and piece by piece, we're going to be able to handle it. And one of the ways that we can do that, one of the ways we can make the cycle of emotional flooding start to decrease is the idea of taking a look and working on what we would think of as automatic processes. So when we breathe in and out every single day. And that's something that we don't think about. Heck, we don't have to think about it at all. If for any reason you had your face in the water and you put your head out of the water after a while, your body is automatically going to take a breath because you need your oxygen to breathe and to live. But the truth is, if we take a moment and we focus on those types of things, then all of a sudden, all the noise and all the fear start to fade away. So if you feel yourself being overwhelmed, whether emotionally or physically, whether you're part of a medically fragile population or not, what I'd like you to do is take a moment, close your eyes, take a deep breath in through your nose and out through your mouth. And do it again. And again. And as you breathe in, you concentrate on the air going in and filling up your lungs and filling up your chest. And you feel the air just filling you up. And then as you exhale, you feel the air going out. And you feel everything kind of relaxing. And what happens when we do that is that all the things that were driving us crazy, all the things that were worrying us, no longer are in focus. It puts it into kind of a muted state where, okay, all I have to do is breathe and things are okay. And I know it seems maybe trivial, but doing something as simple as that is enough to make us realize that we are still alive. We can handle this. We can do what we need to do, and we are human beings. And that's really the most important part. When I think of folks who are taking a look at this and saying, I'm not part of a medically fragile population. I don't know if I really understand what it is that they're dealing with. What I would like to do is I would like to leave you with an example. So indulge with me, if you may. I want you to close your eyes and I want you to have this picture in your mind. So imagine, if you will, you're on a raft in the middle of the ocean. You're covered in head to toe with toxic waste. Your head is on fire. The raft is on fire. You're also surrounded by a bunch of different rescue vehicles. So you have helicopters and boats and different things like that. You're screaming at the top of your lungs for help, but nobody's listening. And that, my friends, is what it feels like to identify as a medically fragile person with a disability. And that is even more amplified by our current situation. So if you happen to have someone in your life that is feeling overwhelmed, whether it's professionally or personally, and really doesn't know how to deal with it, please remember what I said today about the idea of all of the things from triage to increased anxiety and depression, to white coat syndrome, to polytrauma, to re-experiencing trauma, and just take a step back and say, maybe, just maybe, I can help them breathe. Thank you very much.
I don't know about you all, but his words and everyone else who's shared so far has really touched me. So we still have lots of participants here. I want to give you all a chance to connect with each other and connect with our speakers. So we're going to have 5 different breakout rooms. I'm going to go ahead and send the questions, just some prompts in the chat function. So you'll have that to access with your groups. So you're going to be split into 5 different groups. Feel free to use these as jumping off points or follow the conversation wherever it leads you. We'll join back together at 12:50 to be able to ask our speakers any questions if you want to and share any reflections of what you spoke about. And then we'll leave each other from there. So we're just going to get you into your breakout groups and hope you all have a meaningful and worthwhile conversation.
Right. Welcome back. We had such a large group today. We had to do 5 separate breakout rooms. Thank you, everybody, for coming. We kind of pushed up against the end here, but we do have some time for share back questions that anyone may have to specific speakers. Please feel free to use the chat, or we'll try and do the Zoom jumble if you want to unmute yourself. Any comments or feedback, interesting things that came up in your discussions?
I guess my one thing that I want to comment on is that this COVID pandemic has really just shown light, I feel like, for a lot of people who maybe might not understand the current systems and inequities that are in place right now. And so, I mean, I feel like I might be a little hopeful that some things will positively change coming from this.
Lorena, this is Robert. I'm curious, how do you, or where have you seen people understanding? Though we're here on this call, kind of speaking to the choir. So where have you heard or seen folks that are getting it who wouldn't otherwise?
On a personal stance, I would say I've been seeing it in my family. I grew up in Florida, and so Florida, I think has, you know, we're always the crazy cousin. And so just to see, I don't know, the posts of people kind of like speaking to food access and government aid in the sense of like employment, I think has been the 2 places that I've seen people getting like a better understanding of how this isn't, I guess, equal or equitable. And this situation is really bringing that light to people who are experiencing it now. And they would only experience it if it was this pandemic.
Cool. Thanks.
Ashley, you look like you have a thought. Is there something you want to share?
Oh no, we can't hear
Oh no, I
you.
can't hear you.
Oh, she does have a thought.
Okay. Dang. You always have the best things to say. Well, if you want to type in the chat, feel free, but we know you have something meaningful to say.
So Lorena's comment about, you know, hope and positivity, I'm holding on to that too. I think we have a stubborn country, to say the least, but I do feel like, you know, Paul Alderetti made some good points around, you know, we do have an opportunity to pivot to change public health, to change health equities, and hopefully that's something that comes out of this.
Hi, this is Theo, and I think for me, hearing Robert and everybody speak about, you know, I think Robert went more to systems, but it's definitely affecting certain groups. And so there's fear. I think this whole thing is fear-based anyways. I'm not saying intentionally, but it creates a lot of fear for all of us. And so for some of us who think we could go in the community, what are some of the things, the tools that we can take, right? I mean, you know, even wearing the mask when you get out there, sometimes I think the look is different. Certain people are wearing it when certain people wear it. We've read and heard things. So I'm saying, as advocates of public health and people that can make impact in our communities, how do we talk to people? Because they have that historical fear already there, and then with what is happening. Just wanted to say.
I'd jump in real quick to just say in a couple of words, we have to continue to advocate and educate. And it's not going to be easy, and we're going to run into some resistance. To Chris's point, we are a very arrogant and exceptional country and society, and so we got a lot of work to do to break down some of the barriers that come with that. But if, you know, the 98 people that are on here all reach one person and talk about, hey, we should really be thinking about how certain groups are being impacted differently, and what can we do about it, that's going to be exponentially impactful all throughout our state.
And Theo, this is Paul. I've been thinking a lot about that question, and I actually keep coming back to how do we support the leadership in communities so that people within the communities are communicating with their communities to the point, and I was on another webinar where this came up this morning that I think is really critical is, you know, we talk a lot, and there was stuff coming out from the governor's office yesterday and today about enforcement and of COVID-related actions. And even there, it's like, you know, it would be my preference if we give the information to communities that basically they're kind of, and I mean this in a non-harsh way, but they are kind of self-enforcing, so that people are talking to other people in their community when they see something, rather than us, or, and I don't mean just us, but rather than government coming in and saying, you know, put that mask on. If people are saying that to their neighbors, that's a whole different kind of thing.
And then, you know, in response to this question about, you know, policy, 2 nights ago, Boulder City Council said that, you know what, we can't do anything about ballot initiatives and petitions that involves doing anything online. We can't change the way that works. You have to do it in paper. But also you can't aggregate with 10 people or more, and you can't touch people, and you can't be more than, you know, 6 feet, you know, away from anybody. So, or less than 6 feet away from anybody. So they really gave folks no opportunity to get involved in direct democracy unless we get close to each other. And they bent a lot of other rules, like, for example, city council can't meet unless via Zoom or anything technically, but they did. So some of those things that we can advocate for are based in community leadership. So I asked, well, how do people with disabilities do it? If someone can't sign, what's the way that it's done? If we can do that way and verify and validate signatures in general, then how do we do that for everybody, if that is possible? So really looking at the leadership that's been happening over decades, and finding the folks who have found solutions in the past to this. So I'm total agreement, find the leadership that exists and the solutions that have already existed, and follow that trail to making solutions happen.
Thank you so much, Nami, and our speakers in general. Thank you everyone for joining. I know we packed a lot in, but I do hope people walked away with some positive messages and thoughts to take with them. Sarah, I think you had a few final comments too.
I just wanted to share a big thank you to CPHA and Rocky Mountain Public Health Training Center for helping us support and organizing this, and our speakers for joining us. I know Brian wasn't able to join us today, so I included his email below. He would love to connect with you if you have other thoughts or just want to thank you for his words he shared today. Otherwise, we have another webinar in a month on the 27th at 12 p.m. You'll receive communication through CPHA, and make sure we forward you that information. We'll have Chris Gierkin talk about ageism, which is really relevant today. Thank you all for being here, and we look forward to having you next time.